Welcome back, PG learners, to another Anesthesia Learners Academy explainer. We're going to hit the ground running today because we are breaking down absolutely everything you need to know about postoperative nausea and vomiting, or PONV, for your upcoming exams and honestly for your day-to-day clinical practice. You know, this is a topic that affects up to 80% of our high-risk patients, and it's literally cited all the time as the #1 cause of patient dissatisfaction. So we've got to master this. Real quick, though, before we jump into the pharmacology and pathways, just a quick look at the disclaimer here. This explainer is strictly for educational purposes to help you synthesize the material. It doesn't replace professional medical advice or your specific hospital protocols, okay? All right, here's our clinical pathway for today's module. We'll start with a nightmare of PONV, move into pathophysiology and the CTZ, look at assessing the risk factors, hit the antiemetic buffet, and finally, wrap up with acute rescue therapies. Let's dive right into Section 1, the nightmare of PONV, why we must aggressively treat this complication. Okay, we really need to shift our mindset right out of the gate here. It is so easy to just look at PONV as a post-op nuisance, right? Just an unpleasant side effect that delays a patient going home. But guys, as anesthesiologists, we have to recognize it as a severe clinical danger. Imagine a patient who just had major facial surgery and their jaw is literally wired shut. If they're sedated in the PACU with blunted airway reflexes and they start vomiting, they face immediate, life-threatening aspiration. We actually keep wire cutters taped to the bed for this exact terrifying scenario. The stakes are incredibly high. And beyond the airway risks, just look at the physical toll vomiting takes on a fresh surgical patient. The sheer physical act of bearing down and retching causes massive spikes in venous pressure. This can completely burst delicate surgical sutures, especially if we're talking vascular, head, or neck surgeries. In abdominal cases, you're looking at suture dehiscence and potentially incisional hernias. If the retching goes on, patients lose tons of fluids and electrolytes, which leads to severe metabolic alkalosis. So it's definitely not just a comfort issue. It's a massive surgical complication multiplier. Which brings us to Section 2, Pathophysiology and the CTZ, Mapping the Enemy Command Center. This was a huge exam favorite, so listen up. The chemoreceptor trigger zone, or CTZ. You absolutely must memorize its location for the boards. It sits in the area postrema, right on the floor of the fourth ventricle in the medulla. But why is it so physiologically important? Because it lies outside the blood-brain barrier. Evolutionarily speaking, this is our body's built-in radar system. It's designed to detect circulating toxins in the blood and immediately trigger the vomiting reflex to expel whatever poison we might have just eaten. It's kind of fascinating when you look at the two main pathways that feed into that central vomiting command center. It's like a two-front war. On one side, you've got central mechanisms. Think about a patient who's just incredibly anxious, or maybe they smell something awful. That's the higher cortex directly triggering the reflex. Or think of the vestibular system in the inner ear, which relies heavily on histamine and muscarinic receptors. Then, on the flip side, we have peripheral mechanisms. Say the surgeon is aggressively manipulating the bowel, or there's blood pooling in the stomach. Specialized enterochromaffin cells release serotonin and substance P, and those signals fire right up the vagal nerves. Totally different triggers, but they result in the exact same disastrous outcome in the PACU. Let's move on to Section 3, Assessing the Risk Factors, Identifying the Most Vulnerable Patients. And that brings us to some absolute high-yield gold for your exams, the classic Apfel score. This is the 4-point risk factor score you're going to use every single day on the job. You get 1 point for female gender, which surprisingly is actually the strongest predictor. 1 point for being a non-smoker. Yes, strangely enough, smoking is protective against PONV. Obviously, we are never going to recommend picking up smoking just to avoid nausea, but it's an important clinical quirk. Then 1 point for a history of motion sickness or previous PONV, and 1 final point for postoperative opioid use. So, why do we care so much about this score? Well, because of this number right here, 80%. If your patient hits a 4 out of 4 on that Apfel score, they have an 80% chance of experiencing severe nausea and vomiting after their surgery. Let that sink in. For these patients, aggressive multimodal prophylaxis isn't just a nice to have, it is absolutely mandatory. Now, for all of you doing your PEDS rotations, the risk profile looks a little bit different. We actually usually call it POV, postoperative vomiting, since little kids can't reliably tell us if they're feeling nauseous. Interestingly, it's really rare in kids under 3. The risk actually spikes right between 3 and 12 years of age, and then it drops off again after puberty. The specific type of surgery is a massive trigger here, too. Be hypervigilant during strabismus or squint corrections and any inner ear or adenotonsillectomy cases that drag on for longer than 30 minutes. All right, Section 4, the antiemetic buffet, multimodal pharmacological prevention. Before we look at the drugs, here's a critical clinical question for you. If the standard low dose of an antiemetic doesn't work, should we just push a massive dose of that exact same drug? The answer is a resounding no way. Remember those central and peripheral pathways we just talked about? They use completely different receptors. If you max out a single drug, you're just drastically increasing the risk of adverse side effects without actually blocking all the emetogenic signals. We want a balanced buffet. We want to target multiple receptors all at once. So let's load up our plates at this buffet and look at your high-yield first-line defenders. First up, ondansetron. It's your 5-HT3 antagonist and your absolute workhorse. But the exam pearl you need to remember is its risk for QTc prolongation on the ECG. Watch out because that can lead to torsades de pointes. Next, we have dexamethasone. The crucial thing here is timing. It has a delayed onset, so you literally have to give it early at induction, not at the end of the case. Also, keep an eye out for tumor lysis syndrome if your patient has a hematological malignancy. Finally, apripichin, an NK1 antagonist. This stuff works beautifully for delayed PONV because it hangs around for up to 40 hours. But, and this is big, you must warn female patients that it decreases the efficacy of their oral contraceptives. Continuing down the buffet line, let's check out a few other classes. Metoclopramide is a D2 antagonist, but take note, the standard 10 mg dose is actually pretty weak for PONV prophylaxis. You really need 25 to 50 mg for it to do the job, but pushing doses that high severely increases the risk of extrapyramidal symptoms. Then there's the scopolamine patch. It's an anticholinergic that you have to apply 2 hours before surgery, and it is strictly contraindicated if your patient has inguinal closure glaucoma. Lastly, antihistamines like cyclizine, they're very effective for sure, but be ready for strong sedation and stuff like urinary retention in the PACU. Okay, stop right here. This is literally a massive safety pearl that you must burn into your brain. Never, ever give dopamine 2 antagonists, so we're talking metoclopramide, haloperidol, droperidol, or promethazine, to a patient with Parkinson's disease. Parkinson's is fundamentally a disease of dopamine depletion, right? If you block whatever tiny bit of dopamine receptors they have left, you will cause a severe, rapid clinical deterioration. Just don't do it. Now, beyond the meds we push, what about the anesthetic technique itself? Modifying how you do the case is just as powerful as your antiemetic buffet. Volatile inhaled anesthetics are highly emetogenic, so if you've got a patient staring down an Apfel score of 4, you really should consider swapping out the gas for a propofol TIVA run. Propofol actually has its own inherent antiemetic properties, which is a game changer. Also, avoid nitrous oxide. It definitely makes PNV worse. And lean heavily into regional anesthesia blocks. That way, you can dramatically cut down the amount of systemic opioids the patient needs post-op. Section 5, Acute Rescue Therapies. What to do when the buffet fails in the PACU. So what happens when you did everything right? You gave the dexamethasone early, you ran a beautiful TIVA, you did a nerve block, and the patient is still retching in the PACU. Here's your rescue protocol. Step 1, and this is absolutely crucial. Assess the patient's vitals and rule out alternative life-threatening crises. An inferior wall MI or acute pancreatitis can totally masquerade as acute nausea. Don't just blindly push more drugs. Step 2, review the intra-op record. What do they already get? Step 3, based on that, give a rescue antiemetic from an entirely different receptor class. If they got ondansetron in the OR, do not give them more ondansetron in the PACU. Switch it up to a histamine blocker or a dopamine antagonist. Finally, consider simple adjuncts. Have the patient inhale the fumes of a little isopropyl alcohol prep pad. It sounds crazy, but it is surprisingly effective for acute rescue. And speaking of rescue, let me introduce you to a newer kid on the block, amisulpride. This is a recently FDA-approved D2 and D3 receptor antagonist made specifically for PNV rescue. It belongs to the antipsychotic class, but the absolute magic here is that it totally lacks those severe central nervous system side effects like heavy sedation or delirium that plagued all the older drugs in this class. It's an incredible new tool to have in your back pocket. As we wrap up today's explainer, I want to leave you with a bit of a provocative thought. Between a much better understanding of how the CTZ works, the huge push toward propofol TIVA, and these highly specific emerging drugs like amisulpride, will we ever see a day where post-operative nausea and vomiting is just entirely eradicated from the surgical experience? It's a really fascinating goal for us to strive for, and honestly, it requires every single one of us to be absolute masters of the pharmacology we just discussed. And that's a wrap. Thank you so much for joining me today and learning with the Anesthesia Learners Academy.
I really hope this breakdown cleared up the complexities of PNV for your exams and your clinical rotations. If you found this explainer helpful, please hit that like button, subscribe to the channel, and definitely share this with your fellow PG learners. It really helps us keep bringing you guys this high-yield educational content. Stay focused, keep learning, and I'll see you in the next explainer.